And I'm delighted now to introduce Kate Williams, who's also a trustee of the Society of Tissue Viability. And Kate is, you are, Kate, now Associate Director of Wound Care Accelerate, CIC. And Kate's also a member of the Legs Matter Coalition. And Kate's going to be talking to us about the importance of personalising compression therapy. Really important topic. So I'll hand over to you, Kate. Thanks very much.
Thank you, Sarah, for the kind invitation. I'm going to talk to you about personalising compression therapy, as Sarah's just said. It's something which I love to do, and it's something which, in my experience, gets you much better outcomes. Not only short-term outcomes, but longer-term outcomes, and all will become clear. So, way back to the NHS plan of 2019, of course, we're all waiting with bated breath for the new one, but personalised care is within the current NHS plan as a core component of sustainable high-quality healthcare. Now, when sustainable doesn't just mean an environmental point of view, but it's also healthcare that can be sustained with ease. So these patients, a lot of our edema and venous patients have chronic conditions which need to be managed, and it's can the care be, is it easy for them to sustain it? Can they manage it themselves? And without personalisation, it's very difficult to get that long-term ownership of what is a chronic health condition. So it's really important that we understand that personalising compression isn't just about the best product, the best bandage, the best wrap, the best hosiery. It's about the patient that's in front of you at that moment. What is best for that human being with that limb? So I saw a patient this morning, actually, lovely guy who has got the longest list of underlying health conditions. The poor guy's got a really challenging disabilities, lots of underlying health conditions. And one of his frustrations he was telling me this morning is that his hematologist has a focus, we have a focus, we've all got our own little focus. But to him, sometimes he'd rather his condition wasn't, his bloods weren't as perfect, but his legs felt better. And it's so important to get it right for the person, because they're dealing with a lot other than this limb that we are compressing. So getting it right for that human being so that they are comfortable, they are improving, and then once they're managed or healed, they can continue it through life if necessary. So sorry, I can't see the title of the slide, I'll just pretend I know what it says. It's hidden. So what can we do? We need to understand the science behind compression and really be able to explain it to patients and families in a way that they understand. And it's very difficult to explain something in layman's terms in a short way where you're just not waffling on and people zone out. It's got to be short, it's got to be in language they understand. And in order for you to do that, you need to really have an amazing grasp of the science yourself, okay? So it's really understanding the science behind compression and being creative, think outside the box, but be safe. So and you can do that when you understand the physics, when you understand what you're trying to achieve and what each different system can be applied, the implication of fabrics, of stiffness, of different pressures, layers, all the physics and the science behind it. When you get it, you can be more creative whilst being safe. And really, the other thing we really need to never forget is that we mustn't do harm. And my focus really would be through either an act, obviously, but also through a mission. So if we do nothing, if we don't understand the science, and if we don't be creative, and if we don't tailor the compassion to the human that's in front of us, we're not delivering the care that they need. And they won't improve and they won't remain healed. And it is hard because we're not delivering what they actually need. So I wanted to share a case study. I love this story. Richard is a guy who I came across in my previous role, in sunny Leeds, and he is delighted to be used in teaching. He's thrilled with himself that he gets rolled out on study days and the pictures of his legs are shared everywhere because he wants people to learn from his experience. So Richard is a 42-year-old chap. He's got cerebral palsy. He's quadriplegic. I've just noticed the title. And since March 2020, so I met him in February 24. Since March 2020, he slept in bed in his chair. He slept sitting up in a wheelchair. So for 4 years, he slept in a chair. He hadn't had any health input since July 22, where the neighbourhood team, so the district nurses, came in to see him because he had a small wound on his leg. And these photos were taken by the team, the primary care team, who first went to see Richard in February. So the primary care team became involved because a relative rang the surgery really concerned about him. They painted a really desperate picture of Richard's condition and his legs, and he hadn't had any, when I say any health input, he gets his repeat meds, but other than that, he hadn't seen any healthcare professionals for years. So understandably, it was quite odd this happened. So I reached out to Richard. There was no response. There were safeguarding concerns from the call that they'd received. And so they decided to just go and knock on the door. And these two lovely ladies were challenged with that task. So this is Katie and Becky, and they work for the Seacroft primary care team. And they are the ultimate personal connection. This case study would not have had the outcome it did without these two. So they were the ones that went and knocked on the door. So their role started out as it's like a social prescribing role, really, but over the years it's really evolved, and the personalised care that these two deliver is just phenomenal. So they knocked on the door, and without judgment, they slowly got their way in, and the flat was really cluttered, thick with cigarette smoke. The curtains hadn't been open for we don't know how long. And it was a really difficult environment. But these two went in, and the main thing is they didn't judge. They sat there and they just listened. Richard lived with his dad, or still lives with his dad. And these two, when I asked them about today, I have spoken with them before, and they're amazing speakers. This is how they describe their role. We make changes with people. We hold their hands through the process. They don't signpost, they don't judge, they work with people. And so they slowly just went in, had a chat, went back the next week and had a chat. And then they rang me and asked me to come with them. So I did some digging around before I even went to see him. And I found this photograph from February 2022. Remember, that was the peak of COVID. So looking at the district nurse's notes, they had 4 failed visits to carry out a Doppler. They discussed compression hosiery, declined. Dad was changing the dressings, which at the time, at the peak of COVID, if you remember, every relative was changing dressings, and the pressures were unprecedented. So there is no judgment on the district nursing team here. And the wound was improving. Dad was doing a great job. Richard had declined hosiery. The DNs kept trying with the ABPI, but he didn't want them there. He was very anxious about COVID, very anxious about people coming in the house. And so when Dad was changing the dressings, saying everything's improving and ultimately the wound healed, he was discharged. COVID pressures off the caseload. So fast forward back to February 24, I went with Katie and Becky to meet Richard and his dad. And having looked at the pictures, I had a chat with the community matron. We looked at his notes, his history, all these things. And my priorities were really clear. I wanted to go in, get an assessment done, get some compression on, reduce the limb size, and persuade him to go to bed. Having met Richard in only an hour, maybe I was there, it was very clear that we had conflicting priorities. Richard's priority was comfort, not feeling anxious. He was anxious about going to bed. He was anxious about lying flat. He was really anxious about the thought of sleeping in a bedroom. It relates back to housing issues from a long time ago. But he did not want to go to bed, and that was one of his priorities. So already I was on a bit of a, oh gosh, right, even my best charm offensive was not getting me anywhere with this. But the really interesting point when I spoke to Katie and Becky was that their priorities were different. Their priority was to get in the door. They pretty much, in a very polite way, said, Kate, just slow down, hang on, we have to build trust here, because they will just tell us to leave. He has capacity, he's able to do that. So their priority, I learned so much from working with these two. Their main priority was to get in the door. Their second priority was to build trust with Richard and his dad. Their non-judgmental approach just helped this happen very quickly. That really casual, they'd laugh with them, they'd chat away about the families, and it was all very informal and really relaxed kind of chat. And so they built that trust quite quickly. They really, really wanted to understand what's going on. How has it got this bad? And most of all, they approached everything with an air of, well, we just need to get a decent outcome here. We need to compromise. So when you really think about all our different priorities, for me, we all work at pace. We work at that NHS super fast pace, go, 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 go. This really made me stop. I had to stop. I had to slow down because I was not going to be effective at my usual pace of work. So, additional challenges. Richard had agoraphobia. There is a lymphedema service, but it's not a domiciliary service. So, if you want to go to a lymphedema clinic, I am not a lymphedema nurse. I'm a tissue viability nurse, but I've managed over the years and years of working alongside amazing lymphedema clinicians. I have learned a thing or two, which was most helpful. He had really awful anxiety about people coming in the house. So the thought of us going in more than twice a week was, he just felt really anxious about it. Even though it was quite a while after COVID, he was still very anxious about people coming in the house. He was anxious about going to bed. He felt uncomfortable when he was lying in bed. This is what he described. And additional challenge was the house was so cluttered. The bed was in his bedroom. He didn't want to go in there because of the issues with the walls, but there was no room for a bed in the living room. It was so cluttered. And between him and his dad, they had a real mistrust of healthcare professionals. That was really obvious when I first met them. You can tell, can't you, when you first meet people. And I didn't know if dad was a challenge or not. This was the first time I was meeting them. I wasn't sure. I was thinking, is stuff being obstructive? Is he going to be the bigger problem here? I really wasn't sure, but it soon became clear from even just that first visit. Turned out that dad was actually a real positive. My fears were allayed very quickly because deep down, Richard and his dad knew that something needed to change. I mean, look at his legs. Dad was doing moving and handling, not the advanced techniques, but that was something else I needed to compromise for now. And he'd done that for years. He's always manual handled Richard in and out of his chair like that to have a shower. But it was getting harder and harder, understandably, with the weight of those legs. It was getting more and more difficult to dad to help Richard. He wasn't an elderly chap, he isn't an elderly chap, but he was finding it increasingly difficult because of the weight of these legs. And something that became apparent quite quickly was that even in that first appointment, when I was explaining the physics, well, basically, we just need to move fluid against gravity. That was it. Dad really got it. He got it so quickly. He was very scientifically minded. He was a kind of a fixer. He was that guy that would fiddle with a laptop and take it all apart, clean it, and put it back together again. Very technically minded. And they both really got it. They got what the problem was and they got what we needed to achieve. And talking about the science, the physics behind it, and moving fluid against gravity and how difficult it is, the penny started to drop about how important going to bed was. And so from then, so I used to go and visit Richard once every 2 weeks, maybe. It varied, but roughly once every 2 weeks. Katie and Becky went, one of them went twice a week. So you had 2 visits from primary care and then me as and when. But each time I went to see them, the curtains were open the first time I went. There was less clutter. Dad had a family friend who came in. She was amazing, but they let her in. She started clearing stuff. We got a bed in. They didn't want a hospital bed, but we managed to get a divan bed in the living room. The third time I went, the family friend was painting a wall. It was slowly, really, relatively quickly achieved a lot. But we really needed to get the compression on. Once the bed was in place, I'd say he went to bed for about an hour during the day. He was anxious about going to bed at night because his dad wasn't in the room, he was in his own bedroom. So again, it was all about compromise, slowly introducing bed and slowly teaching them about compression. So this was our plan. We introduced compression and bed rest at Richard's pace. I went through short stretch compression bandages, wraps, hosiery, everything to try and just explain, this is how this works, this is how that works. I wanted to compromise. They were willing to try things, but if it wasn't comfortable, he would just take it off, which is, who wouldn't take something off that was uncomfortable? And there was a degree of risk, but it was carefully managed. Obviously, you couldn't do an ABPI. I had no access to toe pressure equipment, but there was no concerns at all about his arterial system. So we knew it was safe to compress Richard. And to be honest, the consequences of not applying compression were really quite frightening. The risk of an admission for cellulitis for him was really quite high. But once again, Katie and Becky were absolutely the key to success. They built that relationship with Richard and his dad. They were willing to learn. I taught them how to apply bandages, taught Dad how to apply bandages. Richard had sensation, so he could just report it and Dad would take off anything that wasn't comfortable. And we went through every type of compression we could think of, showing them samples. And the hardest thing for me really was just to be quiet. My job was to explain the science, provide the tools, and then just, what do you want to do? And that was quite challenging for me because a bit of I talk and talk and talk and talk, and sometimes I just think, no, just shut up, Kate, and let them think and let them decide what's best for them. So letting the relationship build between the girls, Katie and Becky, and Dad and Richard was the key, not me. So I just gave them the knowledge, gave them the tools, and watched them try and do it between them. The girls were applying bandages, Dad learned. I'd go back one day and Dad had a bit of bandage on the foot, a wrap on the leg, and a bit, and I was like, oh wow. But he really understood the science and he understood what he was doing, and he was tweaking that compression to suit his son, so he was comfortable, but it was effective. And the outcomes were just phenomenal. Now, you can see there how it's improved. You can also see, if someone just presented you with that picture from May, you'd go, oh, there's some lovely guttering on that leg, but oh, good God, look at his foot. It's not perfect. It isn't perfect, but it was working and it was improving and it was the best we could achieve for him. Now, as Dad got better and better at this, they could see the improvements. Moving and handling was so much easier. They were so on board. I would just go along. By May, I thought, my work's done here. Dad gets it. He'd ordered new toe caps. We'd got new wraps for his feet. He was trying a bit of compression bandaging with a wrap over it. He was nailing it. And then ultimately, after 12 months, these were his legs. These do not look like they belong to the same person, but they do. And the reason this was achieved, because it was completely personalised for him. The compression was personalised. They were allowed to be creative within safe, it was safe to be creative for him. They could do what suits him. And so he started going back to bed, but even now we must, I'd say 4 hours maximum is when he's in bed and during the day. But that's what works for them, and that's why it's so important to personalise these things. So, to summary, I'm conscious of time I'm going on now. We've got to listen. We've got to listen to the patient, listen to their families. We have to compromise for these complex patients. Think about what's important to them. Collaborate with the patient and the people they trust, not just our MDT. Really understand the science behind it, like I've said already, and be creative but safe. Just no harm through omission. Doing nothing is not an option. And just to finish, there's a really nice chapter in this book actually about personalised care, which is really interesting. And then there's a shameless plug for the Accelerate Advanced Practice course, and I love it because it goes into the details of the science, but then also the creative side of compression, which is fabulous. So thank you. Any questions?
Thanks, Kate. I don't know why you thought about whether, you talk a lot. I don't get that at all. I've never witnessed that.
Hard sometimes to not
Fantastic.
speak. For now, example.
I think people are absolutely blown away by that case study. Even if it had got to the May and that was the best it was going to be, that was a phenomenal improvement. But those
Such a result for
final
them.
photographs, incredible.
Honestly, you'd think I'd made it up when you haven't got a different patient's legs, but I promise I didn't. They are the same guy, I promise.
Yeah, yeah. So a question here is, how did you manage that dimpling? They ask whether it was lipedema. It's not. I mean, it's a byproduct of lymphedema, isn't it? It's like papillomatosis. And
Exactly.
do you want to explain that a little bit more, if possible?
Yeah, so it's not lipedema. It's just where the lymphatics are so overwhelmed that you can get it. They're like little bubbles on the skin, and if you gently press them, the fluid goes out of them. It's just another sign that the lymphatics are completely overwhelmed, not functioning properly, and we need compression. Moisturising compression, mobility wasn't an issue for Richard because of his disability. He couldn't exercise. He couldn't weight bear really. Well, he can't weight bear. I don't know what I'm saying really. But skincare and compression. So it's just another sign that the lymphatics are completely overwhelmed, and we really, really need to support them and get things moving.
Can I just ask you to stop sharing, please, Kate?
Oh, sorry.
No, that's okay. That's okay. Someone's asked about whether maybe you already have, about publishing the case study to use in patient information literature. Is there anything that you've used with this case study in terms of legs matter and stories?
Not yet. No, I am. I just love that team so much. The way those two approach patient care is just utterly inspiring. So I know they're not watching because they're at work, so I'm going to want to announce them, but don't tell
I
them.
was going to ask about their role, the Katie and Becky role.
Yeah.
I mean, how common is that across the different NHS trusts? Because, I think nurses, they say they often haven't got the time that
Yeah.
maybe is needed to go in and build trust in a big way like that. And also there's the problem with continuity of care. But
Yes.
that sort of role sounds amazing. So how common is it, do you think, across the UK?
So each primary care network has been given funds to develop social prescribing. So primary care networks are working at social prescribing in one form or another. This primary care network have kind of gone they've taken the same pot of funding, started with social prescribing, but they've really kind of veered off a little bit into personalised care. So those two are going out, they do the usual, going out to do bloods and checking on the frail elderly, getting people moving, more typical social prescribing stuff. But where they've taken it, they've seen the difference they can make with chronic conditions, not just legs. So this isn't the only thing that they do, but they were so willing to learn. Their personalities help enormously. You could have two different people in that same role. Would it be as effective? I don't know, but they have got the perfect personalities for this job. Um, it's just that their primary care network chose to develop that personalised care agenda more so than textbook social prescribing.
I think it's, it sounds like one of the things that really worked here was also the dad,
Oh,
and his input for sort of that supported self-care. We know that that's not commonplace, don't we? That we haven't got family support or friend support and whatever. So it falls to district nurses or practice
yeah,
nurses to deliver it.
yeah,
But I would imagine this worked because they could go at their own pace, have their
yeah,
bandages done whatever time of the day that
yeah.
worked. That's important too, isn't it?
It's so important, and because so Dad wasn't as reluctant to get involved at first. He didn't want to learn how to bandage. He wanted to stop, but then not stop. He wanted to watch, but then because he was so science, he just gets science and
Mm.
tech and fiddling with computers and machinery and stuff. He just got more and more interested in how this compression was. How does it work? And then he couldn't help himself but start fiddling. So the girls had put a bandage on. He's going, I was rubbing a little bit on his ankle, so I've taken it all off, and I've done this and I've done that, and I've put the. And if you're maybe someone not as experienced, or I don't know what, but it could make you nervous. I could see how someone could go back to an office and go, oh my God, Dad's taking it all off. They're not compliant. They're not following the care plan. They're not doing this. Dad's doing his own thing. It's terrible. Well, actually, it's amazing because what he's doing, his legs are actually improving. It's unconventional, I'll grant you, but sometimes proper personalised care is a little unconventional. These aren't a conventional pair. They're not going to be in a research study any day now, Richard and his dad. They'd be, they wouldn't meet any criteria for a research study, but they get it and they were creative and it was safe and it worked. It's just having the confidence and the support from specialist teams to do that.
Well, it is. It's a really good example of personalised care because it's, we're all different shapes and sizes. We have all different needs. And we can't just be this sort of standardized prescriptive care. We have to tailor it to those individuals. Someone's
Yeah.
asked a question, Kate, about how you determined that he was okay for compression. We have in our previous presentations today, sort of, Annie went through and others around the importance of holistic assessment. And often the ABPI it shouldn't give you any surprises if you've done a holistic assessment. So how did you determine that he was okay?
Yeah. So Richard had no underlying health conditions that suggested his cardiovascular system was impaired at all. That was the first thing. He had no rest pain. When he did go to bed, the reason he was uncomfortable, it was his back. I mean, in an ideal world, you'd say he needs a profile in bed, he needs a sleep system, he needs OTs, he needed all those things, but he didn't want them. So one of my questions was really why are you uncomfortable in bed? Is it that when your legs are up they hurt? But it wasn't, it was his back. He was just uncomfortable in bed. So I know he had no pain and elevation, he had no rest pain, his feet were warm, his capillary refill was good. And when I listened to his pulse sounds with the Doppler, they were really clear, bouncy, triphasic pulses. And he's only 41. I had no concerns at all. But when I can just see the question there from Claire about full compression. So this guy, his ankle circumference, oh, I wish I had it to hand. It was almost 50 centimeters, possibly more. And so what we started was with 2 layers of Actico on a 50 centimeter ankle.
Mm,
It's very gentle. That is a huge cylinder
yeah.
to compress. So 2 layers of compression with Actico really is. I was thinking, oh gosh, is this going to change anything? I couldn't go fancy with the techniques because the girls were doing it and Dad was watching and hopefully learning, which he did. But it was comfortable. That was our first aim, get something on that was comfortable for him because his priority was comfort. So once he was comfortable in it, then we could, and to be honest, it responded to even just what 2 layers of Actico, which looking at the science of it on a huge limb like that, that's very quite gentle compression. But it
And I
was
think it's the
effective.
importance as well, isn't it, as the skill of applying it,
Yeah,
because we know that there's this nervousness around compression, and okay, you
yeah,
could have been having short stretch on, which was required for this limb, but unless it's put on
yeah,
properly and firmly enough, you're getting even
yeah,
less compression. But it's
exactly.
having. So did you have to do? I know that the dad was doing a lot of the care, but in terms of the generalist nurses, did you have to do a lot of training or support with them?
No, there was no generalist nurses.
So they
Katie and
didn't get
Becky are
involved at all.
nurses.
Yeah. But if
They
you had
wouldn't have,
you would have
yeah.
to do that if there was a case where they were
Oh,
involved.
you absolutely.
Yeah.
In this case, if Dad didn't want to get involved and you had to teach the district nurses, you would you'd have to just, it depends on the size of the DN team. If it's a huge team, you just need to cherry pick a few people because you can't teach everybody the personalised thing.
Mm, mm,
Personalised care means a smaller number of people go in. And the shape of his leg, there was so much padding in the creases, so make sure that the bandages didn't dig in all those creases. It it was quite, it needed to be done right, but in a way it was easier for me because there was only 3 people who were ever going to look at these legs, which was Katie, Becky, and Dad. It is more challenging if you've got a big team of community
yeah.
nurses that you're trying to teach. So if that was the case, it would be harder without doubt, but I would just try and pick a handful of people so you're not watering it down too
Mm,
much.
mm, mm.
And I think that would be the most effective way of doing it. But
There's
I
a
think,
couple.
sorry, Sarah, again, struggle to
No,
shut
no,
up.
no, no, that's
Um,
fine. There's a couple of questions here which I really think our next speaker will cover. And
okay.
if he doesn't, it's just around sort of lymphedema and ABPI,
Yeah,
and you know
you'll
the
nail all
difficulties.
that.
Yeah, so I think that's been covered in the next
Yeah,
session. So I'm not going to steal her thunder.
I don't, she'll be much
And
better than me.
but yeah, I can't see any other questions at all in there, Kate. But I think there's comments around the importance of having compassion, empathy, listening.
Yeah,
As you said, slow
yeah,
back off a bit.
yeah,
And
you're not going to get
hopefully.
anywhere like a railroad train going in there, as much as I tried.
And hopefully having a Katie and Becky within your service, which would
Need to
really
plug.
help. Yeah. Well, thanks, Kate. That was brilliant. It just sort of I don't know, I think having a case study like that, it just really reinforces the importance of this sort of personalized care, but also again, the power of compression in turning something
Absolutely.
around. So sorry, I should have put my own phone on silent. So thanks then, Kate.
Thank you.